E, e, it
Okay, and then you're here. Yes. Okay.
Good afternoon, everyone. It is an honor to introduce Professor Ingrid Lundberg. She is a professor of medicine at the rheumatology department at Karolinska Institutet in Stockholm, Sweden. She finished her rheumatology training in 1985, so she's taking care of the rheumatology patients since almost 4 decades. She finished her PhD in 1991, followed by a postdoc at Mayo Clinic in the neuromuscular area, in the neuromuscular unit. And since then, she has dedicated her time to the myositis patients, not only in her research on myositis patients, not only clinical, but also translational research in these patients with a large cohorts. She has received several prestigious awards, and she's a very frequent invited speaker in international conferences. And based on her pioneering research in myositis, she becomes one of the world's leading researchers in myositis. And it's really a pleasure to me to introduce her. Please, Professor Lundberg, the floor is yours.
So good afternoon. Can you hear me? Thank you, Rachel, for your very kind introduction, and thank you for inviting me to your institute. I'm very honored and delighted, and I'm very much looking forward to the discussions in the afternoon on my favorite topic, myositis. So these are my disclosures. So what I plan today is to discuss with you myositis, how the spectrum has evolved over the time, and then depending on the discovery of autoantibodies. And then I will discuss some of our work that we have done on autoantibodies on the Jo1 and the lung, and a new autoantibody, and how we can maybe use the autoantibodies to predict outcome. And also we'll little into T cells, and finally some clinical application on including exercise. So for those of you who are not clinicians and maybe not so familiar with this disease, idiopathic inflammatory myopathies, IIM, or myositis, is a rare disease and with an incidence of approximately 11 per 1 million person years, and a prevalence of 14 per 100,000. It's a bit more prevalent in women than in men. It may affect all ages, including children, but the peak years of incidence for both men and women is between 50 and 80 years. So the major manifestation of inflammatory myopathies, myositis, is the inflammation of skeletal muscle, as you can hear from the name. And the patients experience weakness of the muscle and low muscle endurance, meaning that the muscles are easily fatigued. And it's in particular leg and arm muscle and neck flexor muscles. And in typical cases, you also see infiltration of inflammatory cells in the tissue. And so what we see here are cross-sectional muscle fibers, and the blue dots between are infiltrating inflammatory cells, T cells, and macrophages. But this disease is quite heterogeneous. It's not only a muscle disease, but other organs are frequently involved. And some patients have skin rash, but also interstitial lung disease is frequently seen, arthritis, and even inflammation in the heart, a symptom from the heart. But based on sort of the old description of the disease, and based on the clinical findings and findings in the muscle tissue and histopathology, the myositis group has been subdivided into dermatomyositis with the skin rash, polymyositis without skin rash, a subset called inclusion body myositis characterized by typical findings in the muscle biopsy. But it was also early recognized that there is a subgroup associated with cancer. And then we have the juvenile onset dermatomyositis. Now, the treatment we give to these patients is high doses of glucocorticoids and combination with immunosuppressive drugs. And the effect is quite varying. It's very difficult to predict who will respond. And often the treatment, unfortunately, has limited effects. So we need to improve treatment for these patients. And our hypothesis is that different subsets may benefit from different interventions. And these subsets could be based on autoantibody subgrouping. So we believe that we need to know more about the molecular pathophysiology in the subsets of the myositis, and this could lead us, hopefully, to more individualized and improved therapies. So I will now present to you a case illustrating the evolving spectrum of myositis from the muscle disease to a more systemic inflammatory disease. This is a patient who is a nurse who had a former history of cancer that was cured. She also had deep venous thrombosis after injury. She had asthma. She's a non-smoker. And she presented at Easter some years back with upper airway symptoms. She had pain in her joints, and she was dyspnoic. And she was diagnosed with pneumonia, RS positive, and with pulmonary embolism. She was started treatment, but she didn't really improve. She deteriorated, and she came back 1 week later to the emergency room because now she had also developed muscle weakness and pain in her muscle. She had no skin rash, no Raynaud's phenomenon, and in the lab, she had a clear inflammation with elevated sedimentation rate, elevated CRP, and also the CK level were highly elevated. We use this microcatarrh per liter, where the reference for a woman of this age would be 3.5, and she had 128. As you can see, she also had elevated AST, which could come from the liver or the muscles, where the reference is 0.61. And it became soon quite clear that she had autoantibodies, both anti-Jo1 and Rho52. At the workup, she didn't have any signs of a malignancy. But of course, her major symptoms were from the lungs. And HRCT of the lungs really showed interstitial changes with ground glass. But she also had pleuritis and pericarditis. She had decreased pulmonary function with a vital capacity of 62, FEV 61, and DLCO. And here, for those of you who are not clinicians, this should be at least 80, to be at 80%, to be sort of in the normal range. She also had problems from the muscles, and there we could test her muscles. We use a functional index of myositis test, which measures the number of repetitions, so measures the endurance. And she was markedly weak in all tested muscles. So with this, we performed a muscle biopsy. And in the biopsy, we found lymphocytes, an increased number of lymphocytes. We also found this expression of major histocompatibility MHC class 1 complex expressed on fibers. And this, as you may remember, this MHC class 1 is expressed on all nucleated cells with a few exceptions. And one of them is differentiated muscle fibers. So in a healthy individual, when you stain for MHC class 1, you will see the brown staining in capillaries, inflammatory cells, but not on fibers. And here you see a cross-section of muscle tissue with the muscle fibers, and you can see that some of them are clearly brown, expressing MHC class 1, and with a perifascicular distribution. So now we're coming to the diagnostics of this case. I think for you who are rheumatologists to see patients this is not so complicated, but this is what we now call anti-synthetase syndrome. This was described quite some years back. And this syndrome is characterized by a combination of clinical manifestations, including myositis, as we have here, interstitial lung disease, arthritis. And you can have different combinations of these manifestations. These patients often have fever when they present. Renal phenomena is common, and these skin changes, mechanics hands, which our patient did not present with. And in addition to these clinical features, you are required to have one autoantibody of the anti-synthetases as antigen 1 as our patient had. So for this patient, the woman, her most critical manifestation is the lungs, with the interstitial lung disease. So this guided our treatment, and we started treatment with high doses of intravenous glucocorticoids, followed by high doses of prednisone, in combination with cyclophosphamide, which was given according to protocol, where we give it every second week for 6 weeks, and for 6 times over 12 weeks. And also she was introduced to physical exercise. With this aggressive treatment, she improved, and both in the pulmonary symptoms and in her muscle function. And then we switched the cyclophosphamide to mycophenolate mofetyl. And after some months, she could go back to work as a nurse. And now she's still on some low-dose prednisone and mycophenolate. And I want you to remember this case because I will come back to her later in my presentation when we look more at the molecular, her muscle tissue. But the take-home message from this case is that myositis is still, it's a heterogeneous disease, but patients may present with lung symptoms or arthritis, as our patient did. And it's also important to remember that myositis or muscle weakness is not always present. But sometimes the patients may not have noticed that they are weak, so you have to test them, and then you may find sort of subclinical muscle weakness. It can also be, of course, that because of the lung symptoms, they cannot move so much. And lungs are frequently involved in patients with myositis, and in particular patients with the anti-synthetase autoantibodies. Up to 90% have signs of interstitial lung disease, sometimes asymptomatic. And the lungs are important because they are the major cause of morbidity and mortality in this subgroup. So now this takes us to the next phase of myositis. And over the last 20 or 30 years, several autoantibodies have been discovered. And interestingly, they are quite specific for myositis. So they're not found in lupus or Sjögren. So they are called the myositis-specific autoantibodies. And the largest group are the anti-synthetase antibodies. And we now have 8 anti-synthetase antibodies that are available in commercial assays. And I've already presented the syndrome, which is characterized by muscle inflammation, skin, and lung disease. In the subgroup of dermatomyositis, we also have now specific autoantibodies, and 5 of them have been identified so far. And one of them, the anti-MD5, is strongly associated also with interstitial lung disease. 2 of the antibodies are more associated with skin disease, and SAE in particular is rare, but a very severe skin disease. And then, importantly, 2 antibodies, NXP2 and TIP1 gamma, that are also associated with cancer in adults. They can also be found in children, but without cancer. And then we have 2 autoantibodies, HMGCR and SRP, that are associated with the mainly muscle weakness, muscle involvement, and they are called necrotizing myopathy or immune-mediated necrotizing myopathy. And they rarely have lung disease or skin disease, but they could have a severe dysphagia. And some of these are very difficult to treat. And the HMGCR positive group can be induced by statins. And we see an increasing number of these quite severely ill patients. And then in the subgroup inclusion body myositis, there is one autoantibody that has been identified, anti-C1NA. It's not specific actually for myositis. It can also be present in patients with Sjögren's syndrome or lupus. In patients with myositis, we may also have these antibodies that can be found in other autoimmune diseases, in particular Sjögren, lupus, systemic sclerosis. And they're called myositis-associated antibodies. And one of them, PMSCL, is in myositis associated with lung disease, and I will come back to that also later. But there can also be combinations between myositis-specific and associated antibodies. But importantly now, thanks to these autoantibodies, this has made it possible to identify some new subgroups that are more homogeneous than the previous ones. And there, to this pot, we can now add the antisynthetase syndrome, the immune-mediated necrotizing myopathy, and also, I haven't mentioned that so far, there's the clinically amyopathic dermatomyositis. And these are patients without any clinical manifest muscle weakness or muscle inflammation. So this may help us now to subgroup patients to understand more of the disease. And of course, we should not forget the seronegative. Up to 30% of the myositis cohorts are seronegative. And one explanation could be that we haven't detected their antibodies yet. And one of our PhD students, Lotta Preger, presented this work where she screened for antibodies to all the tRNA synthetases, as you know, that 20 of them, one for each amino acid. And she used the bead array, and in serum from patients with myositis, she actually found autoantibodies targeting 9 additional tRNA synthetases. They're rare, but still that tells us that almost all the tRNA synthetases could be involved in immune reaction in patients with myositis. So then with all these antibodies, are they just helping diagnosis, or do they have a role in the pathophysiology? Well, we don't know that, so we are trying to understand that. And this is one approach that we took a few years back, where we took all our myositis patients in an international cohort, almost 1,500 patients, including Scandinavia, UK, and Czech Republic. And we used the technology with unsupervised cluster analysis based on the autoantibodies and how they merged together. And then we found 8 groups, and not so surprising, Jo1, MI2, but there was also a group with anti-Jo1 and Rho52 combined. So here we have the 8 groups, and one of them is the seronegative, the 8. And the other ones, as you can see, some of them are more homogeneous, like this one, Me2, without any other autoantibodies, and Jo1 with only Jo1 or Jo1 with Rho52. But this group is more heterogeneous with the Rho52. So, but then we used this subgrouping because we were interested to see if they were associated with distinct HLA types, as we have seen like in lupus and Sjögren's syndrome. And indeed, we found now here are the 8 defined subgroups based on autoantibodies. And we found strong associations, both some that we confirmed from before, like the Jo1 with the DRB103 here. But we also found that patients with anti-Jo1 and Rho52 combined had another HLA association, as you can see, with DRB103, but also with DQA and the DQB1. And patients with PMSCL had a specific HLA association as well. And if you compare that to the clinical definition, like for dermatomyositis, you can see the dermatomyositis subgroup ends up, if you take the clinical definition, you find this with different HLA types. But whereas, for instance, the MI2 is very strongly associated with one specific HLA. And this was done by former PhD student Valerie Leclerc and our senior scientist Lina Diaz. So we think this is very exciting because when you have, we found these distinct HLA classes from almost all autoantibody defined subgroups. And for us, this is interesting because the HLA genes encode the class 2 and 1 antigen presenting molecules, which primary function is to present peptides to the T cells. And this can then initiate antigen-specific adaptive immune response leading to production of autoantibodies. So we think this supports the use of autoantibody profiles to subclassify patients for further studies of the pathophysiology. And for this, we have focused on the antigen 1 antibody positive disease, which is the most common of the antisynthetase and is a strong association with interstitial lung disease. And the antigen 1 antibodies, they target the histidine-tRNA synthetase. And this is a bit strange because the histidine-tRNA synthetases are important for protein production and is present in all cells. So why the lungs and why the muscles? So we believe there is some explanation for this. And one observation some years back is that the protein, the histidine-tRNA synthetase, has a different expression in different tissue. And the tissue with highest expression is the epithelial cells in the lungs. And the enzyme, the histidine-tRNA synthetase, can be cleaved by granzyme B in the lungs, for instance, with infections, and then expose new epitopes. And the protein, the Jo1, can also act as a chemokine and attract CRC5 positive cells. So there are some indications that lung is important here to initiate the immune response. So to understand this more, here are some research questions that we wanted to address. So one is which is the major epitope of the histidine-tRNA synthetase? Are there clinical correlations to the epitope reactivity? And are there antigen-specific T cells targeting this protein? So we start with the epitopes, and here we had the possibility to use constructs of the full-length protein. Here, PSRS full-length, and then we use these constructs, the web domain, the CD domain, the ABD domain, and a splice variant including the web domain and the CD and the ABD domain. And we screened our Jo1 positive patients. And here you can see the reactivity to the full length, the web domain, and so on. And you see patients rarely recognize the CD, and not all patients recognize the ABD domain. But the splice variant and the web domain was identified by most patients. So then what we did, we took sera from these patients and also bronchoalveolar lavage fluid from the lungs. And we purified the Jo1 and IgG and IgA. And here you can see the results where you have the reactivity. Here is anti-Jo1 IgG in the ball fluid, and here is the IgA. And you can see there is reactivity both for the IgG and IgA in ball fluid. And there is a reactivity here to the web domain. And here are the similar results from sera. And when we correlated the data, we found that the IgG reactivity towards the web domain here in the ball fluid correlated with poor pulmonary function. So that's another indication that the lungs are involved. What we also did, we had the possibility to investigate lung tissue from patients with anti-Jo1 antibodies and other disease controls. And in the Jo1 positive patients, we found these germinal center-like structures with the plasma cells and not in the disease controls. So again, it seems like there could be an antibody production of anti-Jo1 antibodies in the lungs of these patients. But then you wonder how the immune reactivity starts and how the immune system recognizes these intracellular antigens. And then we had the possibility, using a sensitive method, to actually identify that the antigen is present in the circulation. So now this is the antigen, not the antibodies. And you can see in healthy controls, you have the antigen, full-length antigen, and also the web domain in the circulation. And interestingly, when you have antibodies to Jo1, you have lower levels compared to healthy individuals and the Jo1 positives. So indicating that the antibodies bind to the antigen. So that was the antibody reactivity that we identified to the N-terminal part of the protein, the web domain. So this is also where we search for a T cell reactive peptide in this area of the web domain. And here, in collaboration with Dr. Eddie James at the Benaroya Institute in Seattle, he identified a peptide. We call it 11 peptide. This is the full length HIS-RS protein. And what we use this peptide to stimulate cells from patients with myositis. And the readout we used was the T cell activation with the CD40 ligand, as you can see here in the first column, and also production of interferon gamma, IL-2, and IL-17. And as a comparator, we used unstimulated cells, and these are peripheral blood mononuclear cells. And we stimulated with the full-length protein. I don't know if you see it, but in the middle, oh, here it comes. And then with the peptide. And as you can see, the CD40 ligand is increasingly expressed compared to the unstimulated cells. We also got the nice production of IL-2 and the interferon gamma. So this is from the peripheral blood. And then we had the possibility to investigate blood cells from the bronchial lavage fluid from patients with anti-Jo1. And here you can see the same readouts. And here with the peptide, you have a magnificent increase of the activation marker CD40 ligand on the T cells using the peptide compared to the unstimulated, and a very high production of interferon gamma and IL-2. And that's summarized here, where the lung cells seems to be even more reactive to produce this pro-inflammatory profile. So that means that we have identified at least one peptide that can induce T cell activation. And as I already presented, the presence of anti-Jo1 antibodies or HIS-RS antibodies is strongly associated with one specific HLA type, the DRB10301. So then we set out to develop a tetramer. And for this, we tested different peptides. One with the highest affinity was a new peptide we call 43. And so this is what it looks like. You have the HIS-RS tetramer. And as a control, we use tetanus tetramers, which, as most people in our country, are vaccinated against tetanus. And this work now has been done by our postdoc, Begum Horo. So for this, we managed now, after several years, to identify cells, CD4 positive T cells that recognize the HIS-RS protein. And on this slide, there are 4 patients examples, and we used 2 fluorochromes to identify the tetramer positive cells, and the orange cells here are the HIS-RS positive cells. And we also used other markers that are associated with antigen presentation, the PD-1, CD137, and CD25. And you can see all these orange dots, which are HISRS-specific T cells. And we also measured the production of interferon gamma in stimulated cells after stimulation with the peptide, and unstimulated and stimulated. Here are the Jo1 positive patients, and here are healthy controls and the Jo1 negative patients. So you can see the Jo1, the interferon gamma production in these cases. So this supports that we have identified HISRS-specific T cells. And next, we wanted to analyze, yes? Very, very low. Sorry? Not really, because even in the patients, there are very few. But the tetramer positive cells, I didn't show that, but that's a high frequency as a control.
I was asking because since you're doing the interferon gamma production from healthy donors, it suggests that you get tetramer positive cells in order to have the ability to find whether these cells make interferon or not, right?
Yeah, but yes.
So that is why I was asking how you compare the frequency of these cells from these healthy donors with the patients.
Yeah, I don't think we found any in the healthy individuals of the HISRS specific. But we have used, the controls are also DR3, so they have the same HLA type. So the next step was to analyze if the T cells that are HISRS specific, if they are expanded. And for this, we took the cells and sequenced the T cell receptor, the CR3 region, which is the main domain that binds to the antigen here. And these are examples of 5 patients where we actually found expanded clones. The gray are marked unique clones, and the colored ones are expanded clones. And with the expanded clone, it's the two T cells that have the same amino acid sequences of both alpha and beta chains. But there were no public clones, so they are all different. But this supports that there is an antigen stimulation of these T cells. So what we have found is, we think that the lung, we have supportive data that lung has a major role in the immune activation of patients with antigen-1 antibodies and the identification of antigen-specific T cells. This may be a way for us in the future to redirect the immune system to prevent disease development, but we are not there yet. So then, as I mentioned, these antigens are present in all cells, so it doesn't explain why the muscles become target of the immune system. So to address this question, we used a muscle cDNA library that we screened with sera from patients with myositis. And here are some hits, but our attention was caught to this FHL1 protein because there are several diseases based on mutations in this gene that cause severe muscle diseases in children. And this FHL1 protein is in particular highly expressed in skeletal and cardiac muscle and has an important role in muscle growth. And when we screened our myositis cohort, we found approximately 25% of our patients had antibodies to this protein. And it was rarely seen in other diseases, including genetic muscle disorders. So after some challenges with the method, we managed to confirm the expression of these antibodies in patients in an Australian cohort. And then we found the antibodies in different subgroups of myositis. But maybe the most interesting was that 78% of the FHL1 positive myositis patients were previously seronegative. So they didn't have any myositis specific or associated antibodies. suggesting that this may add to the diagnostic spectrum of using the assay for FHN1. So to understand more of these antibodies, we have now screened a larger cohort from our own side and other comparator diseases. And again, you can see the myositis patients, they had 27% were positive and with much higher levels compared to the other diseases. We also found some in systemic sclerosis and lupus. And then we had the possibility to investigate longitudinally collected sera. And here are the levels of the antibodies in the first serum sample. And then you can see how they drop. And after 3 years, 60% of the patients that were initially positive had turned negative. And those that were seronegative in the first sample, there were a few that turned positive after some years, but with quite low levels. And we found some association with clinical manifestations between the antibody levels and reverse correlation with the muscle strength, the MMT test, but a correlation with CK levels as an indication of muscle involvement, and also disease activity measure called myoac. So it may be that this has an association with disease activity. And to the spectrum of antibodies, we can now add this anti-FHL1, which seems to be associated with severe myopathy. And then we asked ourselves if the antibodies can predict outcome. And to address this question, our former PhD student, Fabrizio Espinosa, he used data from the MyoNet. And here he could use almost 800 patients where we had information on antibodies and damage. So here we used a score called MDI, a damage score, to see how this could be related to autoantibodies. So on the y-axis, we have the MDI, the damage score. And here on the x-axis, we have the time of follow-up. And the red dots are women and the blue dots are men. And you can see the development of the damage by the lines. And here we have the seronegative. And now I come back to the PMSCL group, because PMSCL group had the worst prediction of damage, or the worst development of damage, whereas patients with dermatomyositis antibodies had less development of damage. So this may indicate that having this PMSCL antibody is a poor prognostic biomarker. Why it is like this, we don't know yet. If it's the lung involvement or if we have not treated these patients aggressively. So we are trying to address this now. So now I talked about autoantibodies. Now I go into the T cells. And it's known for quite some time that T cells are really dominating in the tissue of patients with myositis, both the CD4 and CD8 positive T cells in different subsets. But actually, the more detailed phenotype of these T cells hasn't really been presented. So to address this, these are some quite recent studies that we have performed. We used the modern single cell sorting of T cells from the tissue and blood. So what we did, we took biopsies from patients at diagnosis, where biopsy is part of the diagnostic routine. And then we took one sample of this to extract T cells from the tissue. And from the 15 patients, we could extract T cells from 7. And one had dermatomyositis, one antisynthetase syndrome, 2 immune-mediated necrotizing myopathy, 2 IBM, inclusion body myositis, and 1 undefined myopathy. So then we sorted the cells from blood and from the tissue, and we used this SMART-Seq2 sequencing to identify T cell clusters. And this was really a team effort between the clinicians and the immunologists and those experts in bioinformatics in our lab. And using this approach, we could see different clusters And you can see the dominating cells are effector memory T cells and central memory T cells. And here is the whole group, and here are the individual cases. And for instance, this central memory is found in all patients, and also the effector memory and the tissue resident memory cells here. So they are present in all individuals or different subgroups, but with different frequencies. And then again, we asked if these T cells are clonally expanded. And here we have in the muscle, and you can see that there are expansions in all patients with some different frequencies and more expansions in the inclusion body myositis. And the expanded T cells were mainly in the cytotoxic and resident memory T cells. So now this is one example of one patient, and this is actually the nurse I presented before. Now she comes back when we look into detail into her tissue. And here you can see that in her tissue taken before treatment, she had 28 expanded clones. And this is, you can see, there's a lot of information in this plot, but you see the CD4 cells are the brown, and CD8 are the light brown. And the round are from the muscle, and the squares are from the blood. And then you can see the different clusters. But I will move on to the next, because the next slide shows we had the possibility to take one sample after her. As you remember, she got cyclophosphamide and mycophenolate. Then we took another biopsy. She was doing quite well. I would say she was in remission with mycophenolate and low-dose prednisone. And this is what we found. Here are her clones before, after treatment, in the blood, before and after treatment. And you can see here the clones, they're very, very similar. So not really much has happened concerning her, what we think, aggressive T cells. And here are again the different clones. And then without knowing this, because it took almost a year to have these results from the time we took the biopsy, I tried to stop her treatment, and she flared both in the lungs and in the muscle. So I think this may be an explanation that she still has these cells in her tissue, and that when we try to stop treatment, they probably increased and gave her more symptoms. So to summarize this part, I think we can say that we have found that there are clonally expanded T cells, cytotoxic or tissue resident memory features in the tissue from patients with myositis. And these observations may indicate that there are antigens in the muscle tissue that stimulate these T cells. And also importantly, even though we only had 2 cases with a follow-up biopsy, they look the same, and indicating that with our current treatment, we actually don't get rid of these, what we think, bad T cells. So finally now to a little of the clinical implication of what we have done, that's testing the effects of physical exercise. As you heard, I've been in this field for some time. And when I started in rheumatology, I read the textbook, and my supervisor told me that patients with myositis, they are fragile, they should not move, they should not exercise. So we gave them high doses of steroids and told them to rest. But one day in my clinic, a man came and he lay down on the floor and showed me how many push-ups he could do, because he had started to train with his daughters that were elite swimmers. And he was actually doing much better than my other patients. So that made me collaborate with our physical therapist, Helene Alexandersson. She's a physical therapist, and at that time she was a young physical therapist. Now she's associate professor based on the exercise studies. But what we developed first was a very mild home exercise program that was introduced to patients with stable disease, but with weakness. And with this program, we managed to actually improve their muscle strength, and patients were very happy. So we thought this was a right track. So then we have done several studies. One of this is this randomized control study with the exercise group and a control group. And again, patients with stable disease on treatment, but weak. And here they were introduced to biking 3 times per week, and with also other muscle groups that were challenged. This was only for 12 weeks. And here, this is just a summary of the clinical results. Of course, they improved in their biking and in their fitness, but also was surprised to us when we used this core set measure of disease activity, they improved in the disease activity in general. So, which was against sort of the dogma, because we were afraid that training would worsen the inflammation. So among molecular studies we found, one was that we saw an increased number of capillaries in those that exercised. After only 12 weeks, we saw an increased mitochondrial activity. So to summarize, what we and others have found is that physical exercise in all subgroups of myositis is safe, also in early disease, is effective, improves strength and fitness, reduces inflammation and fibrosis, and one mechanism may be due to increased capillary density. So the exercise is now an important complement to pharmacological therapy, but we still don't know the optimal type of exercise. So to conclude, I think we have learned over the past decades that myositis-specific autoantibodies have helped us to identify clinically more homogeneous phenotypes of myositis than we had before. And autoantibodies may be a way to identify biomarkers for severity and damage. And this could be a way for us to understand more of the molecular pathophysiology, and that way to improve therapy and outcome. And phenotyping of muscle cell of T cells in muscle tissue, I think that's the way for us to understand what's going on in the tissue, what's actually causing the muscle weakness. And there are some individual profiles, but also some T cell types that are shared between subgroups. And I think what we see today will open up possibilities to identify novel targets for therapy. And with this, I would also like to invite you, Dr. Rachel, to be part of this international collaboration we call now MyoNet, where we have more than 6,000 patients involved, and that we have started now to be able to subgroup patients according to antibodies and clinics. And I think this is a way to work together with rare diseases. And finally, I would like to acknowledge my multidisciplinary team. At Karolinska, this was at the last Global Myositis Conference in Prague. Dr. Mariam Dasmadji is the head of the clinic, and people working in the lab and clinic, Helena Alexandersson, the physical therapy collaborator, and Marie Holmqvist working with the epidemiology, but also collaborators at Karolinska, in other centers like Amsterdam Children's Hospital, and my, since many years, collaborator Dr. Hector Chinoy and Nir Venkovsky in the MyoNet. So I stop here and take questions. Thank you.
Thank you, Professor Ingrid Lundberg, for your excellent talks. The audience is free to make any questions. If not, I'll start with one. About this new patient, this new autoantibody you were talking about, the FHL1, you don't do it in like the normal assays that we buy. It's not available there. Do you do it in terms of research, or are you doing in routine practice in all patients with seronegative autoantibodies?
We are still working with this in research. We have worked a lot to develop an assay, because the proteins we found it was very difficult to work with. It was very sticky. So now I think we have a good assay for this. We are negotiating with companies that have commercial assays. So I think they are on their way to set up to include it in the myositis profile. But we don't at the moment have the possibility to screen patients, but that's in our plans, and particularly, of course, the seronegative ones. But hopefully we can get this as a commercial assay so we can also screen other cohorts. than ours.
Thank you. Question?
Oh, Vasco. Hello, I'm Vasco. I'm a rheumatologist here. Couple of questions. First, because it's also my area of interest, do you see differences in patients with myositis overlapping with other connective tissue diseases, namely Sjogren's? Because we have a few patients that have antisynthetase syndrome, full-blown, and also Sjogren's. And is there any difference clinically? Because usually, also in the textbook, it usually says, you know, myositis in lupus is mild. If not, question it, and the same for Sjogren's. And then a completely different question was, I think, not sure, I think it was your group that in the past published something about the CD4 positive, CD28 negative T cells, that these were infiltrating also the muscles. And then is that still, are you still looking into it? What is the data on that?
So the first question, whether Sjögren overlap, I had a student who worked with that. We haven't published that. It was with the inclusion body myositis with and without Sjögren. There are different phenotypes because the Sjögren IBM patients are more women. They have a later diagnosis. So, but it's a very good research question. We haven't done that in our whole course. So you're welcome to address this with us. The CD28 null T cells, yeah. So they are very difficult to treat, and we think they are, or we see that they have markers that we can now detect in this single cell. So we are still interested in them to try to target them.
And are those the granzyme B positive that you had there?
I'm not sure, but it's a good question. I will bring it back to my collaborators.
So, something that for me is interesting is related with the autoantibody production and what you see in the muscle. So from what my understanding, you don't have, unlike what happens in Sjogren's syndrome, where you have salivary glands, these ectopic infrastructures with B cells. This is absent in the muscle. So,
not really. We have published at least one paper from us, and there are from some other. There are also in the muscle tissue germinal center-like structure in patients with antigen 1 antibodies. That's the group we have looked for. And as far as I remember, I think it was from Steve Greenberg's group at Harvard. They also found this in patients with inclusion body, these germinal center-like and plasma cells in the tissue. But when you look at biopsies with the pathologists, there are very few B cells or plasma cells in most. So it's hard to say where they are in the muscle, or if we just miss them with our little fish.
from what it seems to me in your single cell transcriptomics, you don't really have a signature of TFH cells or B cells.
No, we only use T cells. We only screened, so we didn't include B cells in this.
Right, but you don't seem to be a clear TFH signature there.
Or I don't know. I don't know how much as I have not done this. I have to go back and ask what markers we used.
So my question is, do you get any changes in TFH populations that could explain the production of autoantibodies?
I don't know. I cannot answer, but I will bring it back. Maybe we can have a discussion on what to look for to understand this. Thank you.
To know about your experience and from the registries, because in our joint clinic with obstetrics, we had a patient with an active myositis that had a fetal death at 37 weeks of gestation, and it seems to be connected with the high titers of anti-Jo1. There are also other centers, for instance, in Hungary, that also had some experience with fetal deaths, late fetal deaths. And I'd like to know if you recommend, for instance, in the next pregnancy, to do heparin like we do with antiphospholipid antibodies. If you have any experience from the registries as well.
So we have We had a PhD student who worked with our registry data on pregnancy outcome. And but there we could not have and that's only the myositis ICD codes.
It was an anti-synthetase.
Yeah, so unfortunately in our registries, we cannot identify the antibodies from that perspective. In that we didn't really, we saw some, I think, small for death, like in other autoimmune diseases. From the clinical perspective, we were part of a report some years back where also the Hungarian investigators were, where we contributed with some cases. And there are variations. There are some reports of the adverse events or serious where the death of the fetus. I met actually one of my patients just a few weeks ago, and she has antigen-1 antibodies. I had 2 children, and she has lung disease and without any complications. So I think we need to know more to collect more cases with this, and we have an attempt to do that. But for the antiphospholipid antibodies, they are very rare in patients with myositis because there is an increased risk of thrombosis in myositis, but we don't know the mechanism. And we screened our myositis patient for antiphospholipid antibodies, and there almost nothing. So this cannot be the explanation, but they have an increased risk of thrombosis. But that
was mentioned, she was also negative. If anti-Jo1 may have an increased risk as well, thrombotic risk, because the patient had a severe placentitis, and it was a thrombotic cause for sure.
I don't
think it's related with the titer, the antibodies, because there were some reports also from Hungary with high titers of this antibody specifically.
I don't think we know so much to have general recommendations, but I think as a physician, I guess that's something to discuss with your patients.
I think we are just on time. Professor Lundberg, thank you so much for joining us, and thank you so much for this amazing talk, and I hope you enjoy a little bit the rest of the afternoon with us. Thank you for the audience.
Thank you.